This is a very brief presentation on a client with right sciatica, which increases with sitting, and a injury to the pelvis and low back from a fall. She presents with rather considerable pelvic asymmetry. I can rotate the pelvis on the left side. On the right side, using the same amount of force, there's a lack of mobility, and the iliac shelf lies lower. Let's have you lie on your stomach, please. We've already screened her hip joint. She has full motion in all directions, has normal strength and sensation distally. The iliac shelf is higher on the right. She has forward mobility on the right side and also on the left side. Good inferior mobility on the left, and on the right side does not move inferiorly. And this is named an anterior ilium. It's my belief that the whole pelvis is moving. I'm not making the claim that the ilium is rotated on the sacrum because we don't have an ability to image the joint in a clinical scenario. I think it's more logical that the whole pelvis is just moved about a axis that's off to the left side, making it appear as though the right ilium rotated on the sacrum. Looking at her sacrum, she has asymmetry on the lower portion. Left sacral quadrant is prominent, and it doesn't move when I try to spring test it. On the right lower quadrant, I can load it and spring it. Same is true for right upper quadrant, and same is true for left upper quadrant. The client has coccyx pain, and she uses a coccyx cushion, and when I palpate the sulcus on both sides, she has a deeper left sulcus, which indicates a left side bent positioning of the coccyx. She also has a 6-year history of shoulder pain, which has not responded to conservative care, and I wanted to show my findings there. She does have full range of motion, but with resisted flexion, she has reproduction of pain. And let's have you lie on your back, please. My intent here is to do just the briefest summary of our findings, and I'm not going to contrast with the right side in the interest of time, but when I spring the right AC joint, I can load it, I spring the clavicle, and it springs right back, and the same thing for the acromion. On the left clavicle, I can load it. I can take up the slack, and then I can spring it, but there's no recoil. It just feels so strange to load a joint and then spring it and have no bounce back. And so what I believe, and the same thing happens when I spring the acromion, when I load it, I'm able to load it in an AP direction, but when I spring it, it goes posterior, but it doesn't bounce back. So certainly strange behavior in the AC joint, and I think that positionally the clavicle has gone posterior in relationship to the acromion. So part of the treatment will be to distract that and then traction the clavicle anteriorly again. And certainly we'll screen the first rib in more detail as well, because that attaches to the clavicle and has an influence on that. So that's my brief introduction to some of the main findings, and we'll proceed with treatment and then do a follow-up filming and see how she responds.